Yeah. So, David, I think it's about time, eh?
Yes, it's time. Let's start. Others will join as we proceed.
Yeah. So, welcome again. We are so excited every time it comes for a Sunday because we're going to learn something in a different way that we're used to learn. So, David, today I have it's very short case, by the way, and I would love to encourage others as I present this case to David. You also think like, what is your approach? What will you do? That's how you'll be learning actively, rather than just listening and participate if you can. So for today, David, we have 29-year-old male who presented to the outpatient clinic complaining of painful testicular swelling.
Okay. Okay. I was trying to write down the complaint first. Yeah. So you say that this is a short case, and Joseph's short cases are very difficult many times. And the complaint itself, testicular swelling. Of course, maybe that's what underscores what a physician should be. Because I mean, quickly hearing testicular swelling, you might think, okay, I think right away I need to refer this patient to a urologist, for example. But physicians are diagnosticians, so you diagnose this patient, and if there's something that requires the attention of a urologist, then you can refer it to them. Now with testicular swelling, because it's not something that we encounter many times, I think I will not have a very good schema. So I'll just quickly mention my thoughts. So if the testicle is swollen, it could be it is swollen and it is painful. So it could be a number of things. So one, you could think about epididymochitis, which of course in a 29 years old male, I will prioritize. Of course, this will depend on the time course and any antecedent history. If the patient has a history of urethral discharge, urethral itching, anything of that sort, so this could be an STI that has extended to involve the epididymis and the testicles, leading to epididymochitis, so presenting with painful swelling. So that's one, an infection, uh, notably STIs that we commonly know, gonococcal, chlamydia, and some others that I'll mention if this is the path that the history will take us. So something else apart from an infection, which again infections can be many, not just not just the STIs that I mentioned. Mumps can do that, and some other things. But apart from infections, another thing that I need to think about is testicular torsion. So maybe the patient has had a testicular torsion. There will be pain. Of course, testicular torsion, at least initially, I think the presentation is more of pain, but I cannot completely separate pain from swelling. So an infection, testicular swelling, a testicular tumor, I think at least initially, it won't present with pain. So there will be swelling, but pain, if at all pain comes, I think that will be later. So based on the little knowledge I have about testicular tumors. But then another thing, you could be dealing with hydrocele. The patient is having a swelling for a long time, and then it has been infected. So a number of things that I'm thinking about: infections, something vascular like testicular torsion, leading to compromise of the blood supply also. but again, lymphatic obstruction with hydrocele and then a superimposed infection, and also neoplasm, so tumors of any kind. So those are my thoughts for now. I do not have a very good schema for that. I'm hoping maybe to develop one today. So HPI.
Yeah, thank you very much. I enjoy listening to you. You say you don't have an approach, but you have an approach. That's so funny. Okay, so let's see. So it started gradually 7 days ago with the left testicle. And then the right testicle followed after 2 days. The pain is dull in nature. It worsens when he walks. It's associated with fever, headache, chills, and night sweats. But he denies painful urination, low abdominal pain, urethral discharge, or blood in urine. He reports that his last sexual encounter was 5 months ago with his girlfriend. There's no sexual contact with a female or male partner since then. He denies weight loss, cough, SOB, rash, nausea, vomiting, constipation, diarrhea, low limb pain or swelling. When I saw him, he said he has completed the 5 days course of IV ceftriaxone and oral doxycycline, but he didn't see any improvement. That's your HPI.
Okay, can I see the previous slide? Now this is interesting and getting incredibly harder. So when at least my picture, my imagination of epididymochitis, which I mentioned initially, is commonly unilateral many times. If someone presents with testicular swelling, if you are thinking of epididymochitis, many times it's unilateral. So started with one testicle and then involved the other testicle. I think so for this particular one, I think I would have to recall very well my anatomy of the blood supply and everything, lymphatic drainage and everything in the testicles. But unfortunately, I think that won't be 100%. Can I see your slides, Joseph? They have disappeared. I'm not sure it's my internet or.
Oh, you don't see them?
Can I see the slides? Yes, I can see them.
What happened?
Urethral discharge syndromes, which can later on extend and lead to epididymochitis. So I think for me, those are still considerations. Can I see the other one? Yes. So no weight loss, no shortness of breath, rash, no lower limb swelling or pain. And then, yes, so this one, the patient completed a 5 days course of ceftriaxone and doxycycline without improvement. So these are antibiotics that we commonly use for treatment of urethral discharge syndrome.
Sure.
And this patient did not respond. So so up to this point, I already discussed for a number of minutes. I'll just summarize. I'm still thinking about urethral discharge syndromes leading to epididymochitis, but I have my reservations. One thing that is unusual, the bilateral testicular pain and swelling. So commonly, for STIs, is commonly unilateral, commonly. So the other thing I said I do not I can't think about any autoimmune disease on the fly that presents with with testicular swelling. But among infections, I think I've spent a lot of time thinking about uh, organisms that cause STIs. So Neisseria gonorrhoeae, Chlamydia trachomatis, Mycoplasma genitalium. So apart from that, I think I should mention that mumps. I think mumps should be a consideration in this patient. We have not had, so this patient is having a headache Now you can see that the head and the testicles are a number of meters apart. So yes, if this patient is having an infection in the testicles, he could present with fevers and night sweats. But what about the headache? And I would be very much interested to know. I'm not sure if Joseph is if he's hiding this detail from me. I would be very much interested to know if the patient has any swelling in the cheeks. So mumps, I think, should also be a consideration. So the STIs, mumps, I cannot think about an autoimmune disease at this point. With tumors, I mentioned the number of tumors, including lymphomas, but then the acuity of the symptoms makes me consider them low on the list. So that's where I am at this point. I mentioned about other things like testicular torsion, uh, infected hydrocele, but then we have not heard of any antecedent history that is pointing us in the direction of hydrocele. With testicular torsion, I think we would expect pain, severe pain, but then fever. I do not see a way to connect this very easily. So I think I'm prioritizing infections. More details, Joseph.
Yeah, sure. That's very nice discussion. So, the universal system, nothing significant. Past medical history is unremarkable. He's not on.
I can't hear you clearly, Joseph. You're breaking.
But can you see my slides? Hello?
Yes, hello. Your voice is breaking. I think it's probably an issue with your internet. I'm not sure if it's mine. Can everyone else hear Joseph? Or you also having trouble like I'm having?
How about now? Can you hear me now?
So the slides are visible. Can you just move the slides and I can discuss while you are fixing? Uh,
Can you hear me now?
yes, I can hear you.
Yeah. My internet today is not looking good. Yeah, so meds, no meds as of now, family and social history. He's a non smoker, he doesn't drink.
So meds, that was the slide after the HPI, or is there any other slide that we didn't see?
Let me see here. So this is
Uh,
HPI,
okay,
and the next slide is review of other system, which is unremarkable. The
okay,
past medical history is unremarkable. There is no meds right now, and the family and social
okay.
history, non-smoker, doesn't drink, relatives are healthy, and that's it.
Okay, let's just move to the physical exam because my thoughts are still the same.
Sure. And here is the exam. So he was alert, he was febrile, was not pale, not jaundice, no lower limb edema. He had bilateral inguinal lymphadenopathy, which were single, firm, and tender. His vital signs: normal blood pressure, but pulse rate was elevated to 110, respiratory rate normal at 16, and febrile at 38.4, starting at normal at Romea. So the scrotal exam, the scrotal sac was warmer, and both testes were swollen, but the right testicle was more larger than the left one. They were firm, tender, but the epididymis, when palpated, were normal. The systemic exam was normal. This is the exam that we.
Okay, that's it. Okay, so I think what is significant here is the vitals, the pulse rate of 110. That is expected with a temperature of 38. This patient is febrile. So when someone is febrile, we expect the pulse rate to increase. So I think that is a normal response. That is a normal physiological response to fever. So That's what I think of. So the fever is telling me, so now this is objective fever, apart from the patient subjectively reporting to be feverish. We have confirmed that this patient is febrile. So fever. So when you think of fever, we know there is a number of things. Infections are high on the list. Malignancy, autoimmune disease, drugs. The patient is not on any medications currently, apart from the ceftriaxone and doxy that he used a number of days ago, and then endocrine issues. So I'm prioritizing infections. I can think of autoimmune diseases, malignancies, or tumors in general low on the list because of the time course. And these testicles are swollen, and Joseph is telling us that the epididymis are normal. So we are dealing with orchitis. So if we are dealing with orchitis, the STIs that I mentioned, commonly they cause epididymochitis. And when you palpate the epididymis itself, it's commonly swollen and tender. So we are dealing with orchitis. Now, uh, does that make me change my mind and take mumps high on the list? I'm not exactly sure, but yeah, I think I will think about mumps. And so far, Joseph has not told us if the patient is having parotid swelling, which I mean, mumps for people his age, it can involve the parotid glands and also the testicles, leading to orchitis. So I'm still prioritizing infections. Vascular issues, vascular issues. Uh, I think they are less likely in this patient, because if you are talking about torsion, I think Joseph would have told us if there is torsion, the testicles are pulled, they are pulled high up, and of course there would be something wrong with the alignment. So I believe Joseph would have told us that. So maybe testicular torsion is low on the list. I'm thinking of infections, and I think at this point, maybe mumps should be a serious consideration. But I should admit that I'm very limited, and therefore anything could be a possibility, and I'm open to learning about that.
Yeah, so you because you asked, when I examined him, he didn't have any swollen the parotids. So let's move on. And labs and imaging, labs were unremarkable, but the scrotal ultrasound had something. So it shows both testes were swollen, the right more than the left. They were hypoechoic with increased vascularity on color Doppler.
Okay, that's it.
That's it. It's a short case.
Okay. Okay, so the issue of increased vascularity, I'm not sure what that means. I mean, because if something, okay, they are both swollen, they are hypoechoic. So them being hypoechoic, uh, and then with increased vascularity on color Doppler, or something that has increased the vascularity. I mean, in the general sense, when there is increased the vascularity, maybe it's a process that has been going on for a while, and therefore there is angiogenesis that has taken place. Now I'm not sure if the same thing applies to ultrasound of the testicles. So what is going on here? We have a 29 years old male with an acute onset of testicular pain and swelling, which is of 7 days in duration, associated with fever and night sweats. No recent history of sexual contact, no antecedent history of urethral discharge. The patient does not seem to have symptoms in any other organ systems apart from headache. And then labs are normal. Imaging shows swelling. They are hypoechoic with increased vascularity. So I can't say that I'm sure what the final diagnosis is. But what I'm thinking of, I'll just mention a number of possibilities that I'm thinking about and see maybe if one of the differentials that I mentioned will be present in the final diagnosis. So I think at this point, mumps will be high on the list, although the point against is that the patient is not having parotid swelling, which is a very common presentation with mumps. And I'm considering mumps because of the bilateral testicular swelling, which is not common with urethral discharge syndromes. So, second on the list, I'm still considering a possibility of STIs. I already mentioned the common organisms and the issues with the duration. I mean, a 5 month ago history of sexual contact does not completely rule out epididymochitis being a thing in this patient. But what is against it? So one thing is unusual, it is bilateral rather than unilateral. And then the epididymis seems to be spared. So it's just ochitis. So that is the thing. And then lastly, testicular torsion doesn't seem to be very likely because of the exam findings that we've been told. So those are my thoughts. I'm not sure what the final diagnosis is. So those are the possibilities I'm thinking of. And maybe if I was attending this patient now, I would start from there, consult some literature and see what makes more sense for the patient.
Yeah, good. So because you examined this patient and found that because you're considering mumps as your number one diagnosis, but this patient on exam doesn't have parotid swelling, do you also still consider maybe you go back in history and is it possible maybe it was back then and then now it's the mumps still there, or
Yeah.
do you
So,
think they have to present
yeah,
together?
yeah. So what I would do is, so first of all, I'll ask the patient if there is a history of parotid swelling.
Sure.
I will do that, and then next, I think I'll have I will have to open something like up to date and see because of course, and the way it is mentioned, of course, mumps is like or ochitis is more of a complication. So young children are not commonly. I mean, the testicles of young children are not commonly affected by mumps, or it can be affected, but when it happens in adults like this one, mumps is a presentation that is common, and then of course it carries a risk of infertility. So I think I'll just need to open an online resource and see if this is a possibility. But I'm highly considering the diagnosis.
Yeah, that was also my approach. And on presentation, he didn't tell me, but after seeing and realizing it can't be sexual, as you're saying here, I asked him, "Did you have this?" And then he remembered. He said, "Yes. 4 days before the onset of this, there was like a swelling anterior and below both ears, and this resolved 10 days. But when he presented on this day to me, he didn't have that." And the thing that I decided to present it here because I thought it's so easy. I've never seen mumps in adults. I've seen in children when I worked as a GP back then. I've never seen it in adults, but I thought it's so easy to recognize. But I realized a fellow doctor had treated this as STI. So I said I should present this. Maybe everyone here should learn, and maybe you ask these patients more and more questions, and things have to make sense. David, you remember I presented to you again previous. I think when we were doing one to one, me and you, a kid who had testicular swelling, painful, and then was treated as epididymochitis, but he wasn't sexually active. And at the end of the day, they opened that kid, you remember, and they saw it was torsion. He lost the testicle. So history, as they say, I don't know, what is the percent they say, David? 90, 80? History and physics.
Yeah. So many people, I mean, different people mention different ones, 75, 80% up
Yeah,
to 90.
yeah.
But of course, it's a case by case basis.
Yeah, after starting doing this diagnosis deeper and deeper, I think it is more than that, but it's okay. Yeah, so yeah, as me and you are on the same line, that this was a mumps orchitis, and then the resolved thing was a dissolved mumps parotitis, and so it's a viral. You do it conservatively. Gave him pure ibuprofen and warm compressions. He called me and said it dissolved after 1 week. So I had to go and read of it, and we learn here together. So the literature says the epidemiology is school-age children and young adults. The transmission is respiratory droplets, direct contact or fomites, and the presentation is fever, headache, myalgia, fatigue, anorexia, which will be followed by salivary gland swelling within 48 hours. Parotitis can be unilateral, but even those which start unilateral at the end of the day, they will be bilateral. So almost always bilateral at the end of the day. Labs, you can have leukopenia, lymphocytosis. I should have done amylase because I didn't know if it is raised. So the patient has already gone when I was reading this. The complications, which is the topic today, number one is orchitis, which is the most common. And it would start 5 to 10 days post parotitis, and it will present with fever, painful testicular swelling. It can be unilateral in 6 to 80%, but you realize 20 to 40% can be bilateral, like in this guy. So, David, the literature reports that impaired fertility of the orchitis is there, but is uncommon. And the treatment is supportive. You just do analgesics, and you give cold or warm packs. Then there are other complications. The one is ophoritis. You find a young girl, maybe 16, they have abdominal pain and fever. You don't understand what's going on. Think of mumps ophoritis. Others, very rare, include thyroiditis, MI, pancreatitis, arthritis. And then you can have neuro complications. Like these are viruses that can cause meningitis or encephalitis or sensory neural hearing loss. To prevent this, you do vaccination, the so-called MMR, the mumps, measles, and rubella vaccine. Yeah, so this was our simple case for today, David. You crushed it very easily. Congratulations.
Thank you very much, Joseph. And I mean, it's so much learning that is taking place here. Uh, if you ask me, and of course you also know that, just think about the last time you read about mumps.
Yeah.
It's probably a very long time ago, and so it's the same thing. I think on this platform we've discussed some cases, some diagnosis which maybe the last time you read about them, it's probably when you are doing parasitology, microbiology, and stuff like that. So we have had rabies here, right?
Yeah.
Uh, yes, we also had, yes, rabies, and many other diagnoses that we do not encounter commonly. And of course, if someone reads it from a textbook, well, because in textbooks, I think everything is plain and straightforward. But then when real patients come, you can see the struggle, like in this patient. So it's something that came later after noticing some things that were unusual. That, for example, when we talk about STIs, commonly unilateral rather than bilateral, and then that's when I started thinking about other things. So I mean, this has been a reminder for me, and a learning point, and of course, it has added to my bank of knowledge. So I believe it has been the same for others, because these are not things that we encounter normally. So thank you very much for the case. Now, if there is anyone who has any comments, any questions before we have some final announcements and close, I think we still have some time today. Anyone, anything that you want to communicate? Okay. So I see the floor is quiet. Um, thank you very much for joining. So I have a quick issue. So on Tuesday, this the day after tomorrow, I believe it will be the 11th, right?
Yeah.
It will be the 11th of February. So that will mark exactly 1 year since we started the first case
Okay.
of since AfroDX started. So AfroDX is turning 1 year on Tuesday.
Sure.
Uh, it's been a huge milestone because, as Joseph said earlier, it started with just the two of us. So we started, and since day one we started on Zoom. So Joseph would present slides to me. So the first case, it's Joseph who had a case and he presented the case to me. We started just two people for a while, and then we thought we should probably expand it. We started engaging our classmates, MED colleagues, and then afterwards we opened it to a bigger audience, and now it has gotten bigger. So even without reminders, uh, every Sunday the attendance is, I think it's an average of 20, because if you see on this platform right now, there are more than 20 people, and that's the case many times. And at times, I think there was a number of times where the attendance was more than 40 or 50, but 20 is the weekly average. So it's not something surprising that when it's open to a bigger audience, there are some days when many people join and then only a few remain, because not everyone becomes very much interested. And of course, some other people have other commitments at times like this. But
Sure.
it's been an incredible journey, and we thank everyone who has who bought into this idea and is joining us every weekend to learn together, because that's the only thing that is connecting us here, learning together. So a special shout out to some people who, since the beginning, since we started sharing with a wide audience, there are people who have, I think, if they missed it very few times. So I think Roland tops the list. Roland is always here.
Yeah, sure.
And then, yes, Seba is also here many times. I think when he's not around, maybe he's just having some other issues. But Seba is here many times, and he has presented some cases,
Mhm.
and he'll present some others in times to come. And of course, I think I'll talk to Seba so he can discuss a case in the recent future. So, and yes, many other people have been joining. Uh, Joshua has also been attending many times. So it's really encouraging. It's really encouraging to see people who are dedicated, because let me tell you something: when you are not discussing and when you are not presenting, listening to the thoughts of someone who is thinking on the fly, it can get boring sometimes. So when you see someone who is ready to sit there and listen, that is someone who is dedicated to learning. So I congratulate everyone who joins every weekend, and we look forward to more learning together. And if you have any thoughts or on how we can improve the platform and improve our learning, please reach out to us, reach out to me or Joseph. If you have any case to present, communicate with us. And if you want to discuss, uh, you can just stop me one day and okay, just on the spot that today I want to discuss a case. I'll leave that spot. If I'm presenting, I believe Joseph will be more than happy to let you discuss. I'll also be more than happy to let you discuss. So let's become more proactive, more engaging, so we can take our learning to the next level. So thank you very much, everyone. Joseph, if you have anything.
Yeah. Thank you very much. It shows. Again, your photographic memory. I don't remember if it's 1 year. I just come here and present or discuss, but yeah, 1 year, that's a lot. And through this, trust me, I've learned a lot through this platform. Sometimes I see a case and think it is simple, but again, I go home and read aloud maybe the management. I realize, oh, it is not like what I thought. I think this maybe David also doesn't know or knows this. So let me present to him and see what he thinks. And then I'll come here and through that, I learn a lot. And, medicine, yeah, it's a job, but it's more than a job. Yes, it's a job that it gives you like the salary and you do stuff, but it's more than that. It's more than that. There is a lot that we do that not other jobs do. So you have to have this engine going and going, like trying to enjoy seeing patients and not get bored. Yeah. Thank you.
Thank you very much, Roland. I see your hand up. If you have anything, please welcome.
Yes, can everybody hear me?
Yes.
Yes, clearly.
Yes. Thank you so much, Dr. Joseph and David, for being visionaries for AfroDX. And indeed, as a medical student, as a postgraduate and medical student, it has indeed helped me a lot. Thanks for also for the compliment that you have given me, but I would also want to extend the compliments to Dr. Aris, who happens to be one of the facilitators at our campus at Kairuki. Also, Dr. Nebo, who actually he was the one who joined me with the links, and from then he has keeping consistently sending me the links to join on every Sunday without a reminder. Also, I'm seeing part of my classmates here, Dr. David, Dr. Matthias, Dr. Modest Kitange, and everybody whom has been keeping this consistency. I'm joining the class and learning. Indeed, as a doctor, the moment when you stop learning, that's the moment when you are dead. In terms of knowledge, and medicine is ever changing. And to keep matters balanced, the way we think it truly differs. So AfroDX for me is that place which balances my thoughts and sees and it makes me see how well could I have done when a case it was to be presented to me. So thanks once again to Joseph and David for this platform. I truly believe the milestone that it has already kept, it will keep on growing and growing and growing. And in the future, I truly believe it's going to be such a very huge platform for people who are knowledge hungry to join again and learn. Thank you so much.
Thank you.
Thank you very much, Roland. I see another hand from Modest. Please welcome. Hello, Modest. I see you unmuted, but I can't hear if you are speaking. I see your hand up. If you have anything, please welcome.
I think he has trouble with the mic.
Yeah, probably. I see you unmuted. So if you unmuted, can you try and maybe raise the volume of your device in order to see if we can pick your voice? Okay. I'm not sure if Modest was trying to say anything, but again, thank you very much, everyone. It's been an honor to have you around, and we hope to hang out many more times together and learn together. So if we are giving some trophies, maybe in the future we can start this. So if we are giving some trophies, Roland will definitely have viewers. Seba would have his, and Joshua Karaba would also have his. He's also very consistent in attending. So thank you very much, everyone. We'll meet next weekend on Tuesday. I'll just share some stats with you because that will be the birthday. So I'll share some stats, and we'll be back next Sunday to have fun while learning medicine. Good night, everyone.
Good night.